Joining me is Julie Tripkovsky, VP of Patient-Centered Care at LHSC. Thanks for coming.
Thank you for having me.
Great. Well, we're going to talk about some of the main things that you focus on, and part of your role is to really work on the mental health area in the hospital.
Yes.
Last year we spoke, and at the time we were calling it a mental health crisis in the emergency departments. There was waits for beds, there was waits to just even get in to see somebody. How would you say over the last year has this changed? Has it changed for the better, worse, the same? Where are we at?
So let me start by saying, over the last year we've again seen an increase in our volumes that are coming to our Victoria Hospital of patients that are requiring mental health services. And we just want to acknowledge our patients and our families that are coming, and in the time of where there's such high volumes, we're really trying to serve everybody as best we can. I think definitely having our government provide 24 beds for us has definitely provided some relief in order to be able to serve as many people as we've been serving. But it doesn't stop there. We still have to think about how do we look at care coordination, how do we look at case management, how do we make sure we have the right resources wrapped around our patients. And I think the other part of it is how do we work closer with our community partners, our regional hospitals, and our LHIN to really create the system that's focused around patients. Ideally, we'd like to see a system where patients have access prior to coming to the emergency department. I've heard from many families and patients that when they come to the emergency department, it really is the last resort for them. And so I'm trying to think about how do we create that system or that availability of service for them in the community, and so there's earlier intervention. So those are some of the priorities that we'd like to see worked on in the future. But most definitely, I would still say, we're very challenged with serving the amount of people that are coming to us, but we're very committed to making sure that they have high quality, safe care.
Last year when we spoke about seclusion rooms, and you were just saying that you are having a high volume of people still coming to you guys, and at the time, I know when we were doing the interview, you had mentioned that sometimes seclusion rooms are used for an overcapacity situation. And for those who don't know, seclusion rooms would be rooms where mental health patients are under security watch. It's a very empty room. But if the wrong patients are, not the wrong, but patients who don't necessarily maybe need that much of a secure environment are going in there due to an overcapacity issue, that's a problem. Is that still happening? Are you guys still using those rooms all the time? Are you trying to avoid using them when not needed?
So maybe I'll just take a step back and just walk us through sort of the seclusion room process. A seclusion room is utilized first and foremost. We look at the acuity of the patient and if the patient needs to be in seclusion, and we make sure it's really about a patient's safety and risk, right? So utilizing seclusion for a short-term period to make sure patients are safe. The second part of, I think, your question is looking at capacity and capacity planning. Has there been times where our emergency department is overwhelmed with mental health patients that are waiting for beds? Do we have to use the seclusion rooms? Yes, we do. We have. I think we're seeing less and less of that. We're really looking at who is the most appropriate patient to be in those rooms. And the emergency department staff and our centralized psychiatry service that we have in the emergency department, they really work together to assess our patients to really try to understand who needs to be there from a safety perspective. And if we do need to use that capacity, what we term as sort of unconventional capacity, we actually work with our teams to make sure that the appropriate monitoring and watch of the patients is aligned with the level of care that they need.
Some mental health experts that I had spoken to back then, and even now, would say a room of that nature would, in some cases, elevate the way a patient is feeling. Is that something that's taking into consideration, or something you guys have been looking at ever since we've chatted since last year?
Yeah, I think so. A couple things. I think seclusion rooms are available generally in all emergency departments. Ideally, it's a form of treatment that's supposed to be short-term treatment. We're definitely looking at what's the most recent literature and best practices around that. But I think ultimately it comes down to what is the best safe environment for a patient. And sometimes we have patients that have either taken let's say some type of drug that need to de-escalate, need to be doing it in a safe environment. So seclusion could also be utilized in that environment. But we're definitely looking to see what we can learn from our current counterparts across the province and really trying to understand how do we best serve our patients.
I was recently speaking to a patient and their loved ones about who had stayed at the mental health ward for an extended period, also stayed in the psychiatric intensive care unit. And part of their concerns were that they kind of voiced to me was that it's not the most therapeutic environment, in their opinion. And they also felt that maybe more empathy was needed, or more of a therapeutic kind of environment. Now, of course, there is the center across the road run by St. Joe's, an inpatient center, but there's a wait for it. So you have patients, you know, over at LHSC waiting in some forms to get into there. But what is being done at LHSC, though, to kind of help make that transition, or maybe make that more of a therapeutic environment for those who might be feeling, it might not be a seclusion room, but they say it almost feels that way?
I think there's a couple things. One, I want to just acknowledge any family or patient who comes forward and says, you know what, this doesn't work, because we need to know that so we can think about what do we need to do differently. Excuse me. And I think the other part of this is really trying to understand, you know, when we think about moving mental health forward, what are the types of therapies and treatments that we need within the acute care setting, and then what could we provide in the ambulatory setting, and really trying to understand each of the populations that we're serving. How do we best do that? I just want to acknowledge our partners at St. Joe's, because they too are, you know, struggling with capacity challenges, and you know, they come to the table, they're collaborative, they're really working with us and with our regional partners to really try to understand how do we collectively as a whole serve patients. But you know, we're struggling with capacity, and so you know, I wish that I could say to you, Celine, tomorrow we're going to turn the lights on and we're not going to have capacity challenges. It's going to take some time, and I think the only way that we're going to be able to do this is as a collective whole and through secured partnerships like we have with St. Joe's.
This individual waited about 2 to 3 days, they claim, and their family members on a stretcher, they said, in the hallway of Emerge to get into a room. Some people I've heard of wait 4, 5, 6, 7, 8 days. Is that the case? And what do they mean by just waiting on a stretcher in the hallway? Are they just in crisis on a stretcher?
No, so we do have a, you'll recall, we do have a centralized emergency psychiatry team that's right in the emergency department. We've also augmented that team with having more psychiatric mental health nurses right in the emergency department. So while patients are waiting, that we are actually making sure that they're getting the appropriate treatments and care plans developed. You know, the realities are that we still are having our capacity challenges, and until, you know, April 1st week where we opened our new capacity, we were struggling. We had occupancies around, you know, 140 to 160%, and trying to make sure we're moving patients through the system. It has been a challenge, but we're very committed in trying to understand, you know, internally we're doing a couple of things. We're looking at how do we streamline our care plans, how do we make sure that we're partnered with the right community partners to make sure that when patients either leave us to go to the community, or you know, they're going to Parkwood, that we're working with our partners earlier and really thinking about what does that care continuum look like early on, to make sure that our patients are flowing through the system.
Those 24 beds, is that enough? And if not, what needs to be done further?
I think, you know, there's probably, I think for LHSC, that we're hoping that is enough capacity, but that will only be enough capacity if the right resources are committed to the community setting. We definitely need more housing. We need more probably crisis services, addiction supports. I think these are all of the elements of a mental health system. And I know that recently the government announced, you know, more access to psychologists and treatment in the community. These are all early interventions that we really need. Our goal is to make sure that we're diverting folks from the acute care setting, because we should definitely have enough beds for who we're serving in our community. Looking at it from the perspective, if our populations continue to grow, that might change, but we are hoping that if the right investments are made, that will provide some relief to our own system.
You mentioned diversions, so we can talk about that, because it's been over a year now being worked on between LHSC, partners at CMHA, EMS, to divert up to 3,000 mental health patients who are not acute, so that they don't go to the emergency department, and instead EMS can transfer them to the crisis center on Huron Street, CMHA's crisis center. It sounds great in theory, and a plan that you guys have worked on so hard, and yet it keeps getting stalled by the province. And now that they've opened up the Ambulance Act in December, I think some partners like EMS was really thinking, this is it, we're going to be able to finally do this program, and it's still not happening. That's got to be frustrating, because that could ease a burden on the emergency room.
So I just want to, that's a big question, so I just want to tackle it in pieces. So let me just say that I want to acknowledge our partners in the EMS side of the house, Chief Roberts and his team, and Beth Mitchell and her team at CMHA. They've really been great partners. We've really been trying to work collaboratively to think about what can we do to ease the pressures for the emergency department and ease the pressures on EMS side. You know, we have legislation and we have to follow legislation. The hospital has the Public Hospitals Act that we follow. EMS has their legislation. I think in creation of our satellite crisis center, what we've tried to do is say, where can we live within the parameters of that system? We know that the patients that are being diverted to our small satellite crisis office we have on site, you know, the volumes probably could be higher. They haven't been too high, actually. And so what we're trying to do now is say, well, we have this resource on site. How can we utilize that resource potentially to actually give crisis intervention to people that are already in the emergency department? So we're evolving models, and I think, you know, as legislation evolves and allows us to do things differently, then we will evolve as well. But right now, we're really planning and monitoring for our patients within the bounds of our legislation.
Even with the satellite center, I mean, you look at the numbers that EMS has shown us, and you're looking at 3, 4 to 6 hours pretty much for a patient that's not really in a massive crisis, sitting in a merge, opposed to maybe 15 minutes at Huron Street. So yes, there's a satellite center, and yes, obviously you guys are trying to monitor that, but what would you like to do, or what would you like to see happen in theory, moving forward?
Of course, ideally, we would like a diversion plan where we see people going back to the community, or if they need acute care, you know, they get that intervention and go back to the community. But we're really planning with the system that we have, and I think ideally we're trying to understand who can we potentially treat with a crisis worker and then follow up with our medical team. As part of our own legislation, when a patient comes to the hospital, that medical intervention and assessment is a requirement by legislation. So we really are working within the system that we have. Ideally, our community resources and legislation and hospital resources and legislation would be aligned, but until we get there, we're going to make it work as best we can for patients.
You want to briefly explain how that satellite, because it started in December, the satellite site works?
Yeah, so what happens is EMS actually comes through the front door. They have criteria that have been developed by our medical directors and medical leads, and if a patient meets the criteria, they can divert the patient to our crisis center. We also triage the patient because we need to know that the patient's in-house, so they go to triage, get registered, and then they get diverted to the crisis center. The crisis team actually does works with the patient, tries to understand what the issues are, and then they go into the emergency department to make sure that there's no medical condition or any other interventions that are required. And then hopefully at that point in time the patient is released home.
But it's safe to say, and you kind of mentioned this already, but we'll ask again, that it would be key to maybe not have people come in if they don't need to. So that would maybe be the prevention and actually getting people talking to the right organizations and the right partners. But even when they leave, I mean, you have people who come in crisis and then they de-escalate. You guys de-escalate the situation. They're out the doors. They're back again in a week. So, I mean, and that's got to be a frustrating cycle. You got to stop that, right?
I think there's a couple parts there. I think the first part is we're always going to advocate for community resources because they haven't grown just like our population has grown, and we definitely need those community resources to be put in play. And I think, when there's also an onus on us that when people leave, we also have to educate our patients and families around what are the services in the community. So when you leave the hospital, if you now that you know about the crisis center, you absolutely can go to Horton Street. You don't need necessarily an ambulance to take you there. It's part of the onus is on us to educate our families and our patients about that resource being in the community. And I think we're going to continue to work and treat patients to the needs that they have and the acuity that they present with.
And then you've mentioned improvements over the years, over the last year. So what improvements would you also like to see, and that you guys are working on moving forward into the rest of 2018 and for the years to come?
So I think, definitely we're looking at, again, as I mentioned, streamlining the care pathways for our patient and really understanding what needs to happen within a hospital setting and what needs to happen in the community setting, and how do we bridge that continuum. I think the other part of this is really looking at those community resources and how do we help build those community resources. We've been doing some work with our LHIN and regional planning and thinking about care coordination and case management, developing standardized pathways across all of our hospitals so we're all treating patients for this, you know, in the same way for similar disease states. And I think the other things that we're doing, and really a neat initiative I want to share with you, you know, mental health has really become a specialized service, and making sure that our nurses, our frontline nurses, are really up to date for the treatments and interventions they're providing patients. We've partnered with Fanshawe College, and they have been, you know, what I would say, provided a 3-day training course, and we've been working with them, and they have been phenomenal partners. And so we're providing that training and education for our nurses, and we've trained 158 nurses. So we're really proud of that, because I think that's the next evolution of what we need to do, is really understand what's happening with our mental health population, and how do we serve our patients differently and in a better way, focusing on, you know, quality and safety in our patient experience.
Perfect. Well, thanks so much for joining us, Julie.
Thank you very much.